Let's begin with a cat gallbladder. Place the transducer in a perpendicular position near the ventral midline and to the patient's right side of the xiphoid. Angle the transducer cranially to find the liver. Adjust depth so that the liver fills the ultrasound screen from the top of the screen to the bottom of the screen. The diaphragm should be to the left side of the ultrasound screen. Fan the transducer to the patient's right side to find the gallbladder. If necessary, rotate the transducer clockwise or counterclockwise to find the long axis of the gallbladder. If necessary, slide the transducer along the rib to the patient's right side. Decrease depth to magnify the gallbladder for study. Decrease gain in the area of the gallbladder to reduce artifact. If needed, apply pressure to the transducer to get it closer to the gallbladder for a better image. Press the freeze button and release pressure on the transducer. Use cinematic loop to scroll backward or forward to find the best image. Place an arrow on the gallbladder, label the image gallbladder, and save the image to the patient record or archives. Unfreeze the ultrasound machine. Fan the transducer slowly to the patient's right side till the gallbladder disappears. Then reverse directions and fan to the patient's left till the gallbladder disappears, to be sure you have seen all of the gallbladder and its contents. If I see or suspect a lesion of the gallbladder, I rotate the transducer to a transverse position, fan cranially, and then caudally to see all of the gallbladder and confirm a lesion in a second view. Then I rotate back to a sagittal or long axis position. The normal gallbladder is usually a balloon-shaped anechoic organ a little to the patient's right side of the ventral midline. The gallbladder is usually oriented from cranial to caudal. When you adjust depth so that the liver fills the ultrasound screen from the top of the screen to the bottom of the screen, the gallbladder usually takes up about half of the depth of the liver. The gallbladder wall is a smooth, hyperechoic line. The gallbladder acts as a reservoir to store and concentrate bile from the liver. Normal bile is anechoic. Concentrated bile is called sludge and appears gray on ultrasound. A small amount of sludge may be normal in dogs. It is unusual to see sludge in cats. Much more detail and examples of lesions are shown in the gallbladder DVD. Landmarks are important to help you find the organs you are searching for, especially if you do not recognize an organ that is not normal in appearance. The diaphragm is cranial to the liver and gallbladder in the sagittal view. The gallbladder is usually surrounded by liver. The stomach is caudal to the liver. Near the ventral midline, falciform fat is often seen ventral to the liver. Many artifacts are not fully understood and are difficult to explain. I will explain some artifacts as I understand them at this time. In the Tips and Techniques DVD, we showed that the ultrasound beam and the reflected return is partially absorbed and weakened as the beam penetrates deeper and deeper in a homogeneous tissue like the liver. We showed that the time gain compensation toggles are used to enhance the ultrasound beam and the reflected return at increasing depths to obtain a homogeneous image in a homogeneous tissue. The normal gallbladder is not the same echogenicity as the liver. Normal bile in the gallbladder is anechoic. That means there is no absorption, weakening, or reflection of the ultrasound beam by normal bile. In spite of that, we have enhanced the ultrasound beam in the gallbladder. In training, we depict the ultrasound beam as a single beam from the transducer. If we rotate the transducer 90 degrees, the beam would look like this. There is a powerful central ultrasound beam, and the ultrasound machine assumes it is the only one. However, in reality, there are also multiple weaker lateral beams called side lobes. Any return from these weaker side lobe beams is usually overpowered by the much stronger central beam. But in an anechoic structure like the gallbladder, the ultrasound machine assumes that weaker return from the side lobes is coming from an equivalent location on the central beam. In the example depicted, part of each side lobe is not in the gallbladder. The weak side lobe return from part of the gallbladder wall and liver is mistakenly shown as being in the gallbladder. This may be called side lobe artifact or slice thickness artifact. Because it resembles sludge, it may also be known as pseudo-sludge. Side lobe artifact usually moves with transducer movement and patient respiration, whereas true sludge would not move with the transducer. Use the TGC toggles to reduce gain in the area of the gallbladder to reduce or eliminate side lobe artifact. When imaging the liver and gallbladder in the abdomen, it is common to see what appears to be liver and gallbladder on the thoracic side of the diaphragm. What we are calling the diaphragm is actually an interface between a fluid density, the actual hypoechoic diaphragm muscle, and a gas density, air in the lungs. In the Tips and Techniques DVD, we learn that gas strongly reflects the ultrasound beam. When imaging the liver and gallbladder, the ultrasound beam passes through and creates an image of the liver and gallbladder. Then the rest of the beam is strongly and completely reflected from the gas interface at the diaphragm and passes back through the same tissue in reverse order. Because of the time delay, the ultrasound machine assumes these reflections come from the other side of the diaphragm. The curve of the diaphragm also causes some refraction of the return. It is important to recognize mirror image artifact. Do not automatically dismiss everything on the thoracic side of the diaphragm as mirror image. the heart, thoracic masses, or pleural effusions in direct contact with the diaphragm will also be seen. Adjusting depth to fill the ultrasound screen with liver helps reduce the mirror image artifact. Placing the diaphragm to the left side of the ultrasound screen also reduces this artifact. The gallbladder wall is measured by placing one caliper on the outside of the gallbladder wall and another caliper on the inside of the gallbladder wall. In dogs and cats, the gallbladder wall should not be more than 2 millimeters thick. I do not routinely measure the gallbladder wall. Normally, the wall is a thin, flat, hyperechoic or white line. When the gallbladder wall is contracted, it appears rough and irregular, but if measured, it is still within normal limits. When the gallbladder wall is infected, inflamed, or edematous, it will measure greater than 2 millimeters. I do not routinely measure the gallbladder volume. I only measure it if the gallbladder looks overfilled to me. Most ultrasound machines will make volume measurements. In the sagittal or long-axis view, measure the gallbladder length from cranial to caudal. And the height from ventral to dorsal. Then rotate to the transverse view and measure gallbladder width from right to left. If your machine does not calculate volume, multiply length by height by width by 0.53 to equal volume in milliliters. As a general guideline, gallbladder volume in milliliters or cubic centimeters is equal to the animal's body weight in kilograms. This cocker weighs 15 kilograms. We expect about 15 milliliters of bile. Measurement shows 46 milliliters, indicating an overfilled gallbladder.